So I'd like to introduce our speakers today, starting with Dr. Thomas Hall, who is Director of Prevention Treatment and Recovery Services at the University of Central Florida. Dr. Hall is an expert on strategies and best practices to engage campus administrators, health and wellness professionals, counselors, and medical providers to support efforts designed to prevent collegiate prescription drug abuse. And as well as Dr. Hall, I'm joined today by my colleague, Kimberly Timpf. Kimberly is a Senior Director of Higher Ed Partner Education here at EverFi. She's been with the company for over 10 years. And here at EverFi, she helps build institutional capacity and support for prevention by sharing insights and recommendations with senior leadership and key stakeholders as part of on-campus briefings. On the whole, Kimberly has spent more than 20 years in the field of college alcohol and other drug prevention. And she's worked at both public and private universities. So now, to start with today's presentation, I'd like to hand it off to Kimberly, who will be taking the lead here.
Great, thank you, Michaela. And thank you everyone for joining us here today. I know that from the list of registrants, and initially around 700 at this point, and the varied backgrounds of the folks on the line, that this is certainly a topic that is top of mind for folks on campuses, in many areas of campus. There are certainly a number of challenges, some of which we'll touch on today. And as a result, I will say, and I will give more information and speak a little bit more specifically to this near the end. As a result, we have an online course that we're going to be adding to our course catalog to address this, prescription drug misuse and abuse on our campuses. And so, to begin the conversation today, or to begin this presentation, I wanted to start with identifying a little bit the scope of the challenge. And again, to many on this call, this is certainly probably not new information, somewhat familiar, but because we do have such a broad representation, I want to make sure that we're all kind of, starting from the same, framework in terms of the challenge. So first is to just identify and acknowledge, and this is data from the United Nations Office on Drugs and Crime, and this is a 2011 report showing that the United States consumes 75% of the world's prescription drugs. So even though we make up just 5% of the world's population, we do live in a country that is very, very much, not quick in a necessarily a negative or positive way, but just, is quick to prescribe for a number of different ailments. It's a very commonplace, let's put it that way. And there is very little stigma associated with it in this country as well. And prescription medications do play a critical role in healthcare, and so that's a really important point to keep in mind. So as we have this conversation, making sure not to stigmatize this as only an issue of abuse, misuse and abuse, but to really understand the role that it does play. And advances in drug discovery and development really help us live longer and live healthier lives, but any medication can cause harm. And the misuse of prescription drugs certainly has become, a serious public health issue, if not epidemic, in much of the research literature. The contributing factors, in addition to kind of more the broader societal implications, is, access. So access is a huge contributor to this, but the United States is one of only 2 countries that allow pharmaceutical companies to directly advertise to consumers, which I think is another important piece of this puzzle. If you watch television, we all know we're bombarded by advertisements for different prescription drugs. We see it in magazines, on billboards. I know in Boston, where we are, there are currently advertisements all over public transportation and the train stations for a number of different drugs as they get introduced. So, it would be, Dr. Dennis Dimitri is president of the Massachusetts Medical Society, and has said, we would probably be better served if we had advertising more aimed at raising awareness of the issues of substance use and available treatments, and feels and believes strongly that advertisements should focus on treatment as opposed to pushing the demand for one particular medication. But as we all know, those particular challenges. And so the last factor I will point to is around prescription medications is, that it is commonplace, and the belief that, because of that, the belief that it's safe because it's prescribed by a physician. So overall, there's really little negative stigma attached to taking pills. And so I think an important part of this conversation also is we look at the definition of misuse. In our course, one of the things that I think we've been very deliberate about is making sure to identify misuse and abuse and to not confuse those. So as we're educating students, as we're thinking about prevention initiatives, that we really do focus on what misuse is and when and where it overlaps into abuse, but always keeping those two separated in order to have that conversation. So taking more of a prescription, taking a prescription medication for a reason different than prescribed, and sharing or taking someone else's prescription medication is really, how we're thinking about misuse in this perspective. And then Tom's going to talk certainly about abuse. So the most commonly misused prescription drugs actually fall into three categories, and this is again something that I think is an important part of the conversation, and yet there really is much of the focus really goes mainly to stimulants because of the abuse of ADHD medications such as Adderall, Ritalin, and Concerta. So we go into and think about kind of what are some of the what are some of the side effects, making sure we're educating students on why it works, but also why these things can be dangerous when it's not prescribed. And so then there's depressants, which are used to treat anxiety, and the brand names you see up here, the Valium, Xanax, and Ambien. These work by keeping stress-related nerve impulses at bay, and these can certainly cause, drowsiness and seizures from withdrawal, and a number of different side effects, and potentially, obviously, more problematic when it's not taken or when it is abused. So finally, we have opioids, and this is drugs certainly have fallen into the category then all over the news, especially in the past 2 years. And these include the brand names like fentanyl, Percocet, and Vicodin. And these are really those drugs used to control pain that affect regions of the brain that trigger euphoria. So, but they can also, have a lot of negative side effects as well. So I think it's again, another part of this is, where do we focus our efforts? We see that if we look at overall abuse by different drugs, we see that the #1 drug of abuse is opioids. So, but we also pay a good deal of attention on college campuses, or what gets a great deal of attention on college campuses is certainly stimulants. And the reason that is because if we look at the data, if we break down the data, even though opioids are the most abused nationally, when you compare the difference between college students and all 18 to 25-year-olds, stimulants, college students are twice as likely to abuse stimulants than students in that same age group. And then you see the distinction between opioids and depressants. So again, just some kind of points to consider as we just think about this issue and some of the contributing factors and how we have, gotten to this point in our history, particularly around how we look at substance use on our college campuses these days. Before I turn it over to my colleague, I do want to, again, thank Tom Hall for joining us. I've known Tom for a number of years, and he's been doing this work, great work at University of Central Florida, and I'm really excited that he's here today to put some context to this and to get us thinking, about how do we start to look at prevention initiatives focused on this issue, and what are some of the challenges that we may encounter. In planning this webinar, we did identify that we could have had this could be a 10-part series, obviously. So, trying to keep it as high level as possible, but also providing some helpful information is really the goal. And we're happy to continue this conversation and to answer and respond to any questions you have, and potentially have that inform future webinars and other resources that we certainly at EverFi are happy to provide. So Tom, take it away.
Thank you, Kimberly. I appreciate being here, and I'm looking forward to the next 40 minutes or so. So there's a lot we can learn from the 2002 Surgeon General's call to action related to alcohol abuse strategies. One of the issues with prescription drug prevention as compared to these strategies for alcohol use is the stigma attached to drug use. And I think that that's a challenge for us as professionals, is how do we effectively teach skills to students and provide information without risking the impression that we're implicitly supporting drug use. So I tested this theory recently. Last Saturday, I was at a dinner party with a bunch of people that I've been friends with for over 20 years who are community influencers. They're on boards of hospitals and lots of community boards, lots of community service. And so, I was actually thinking I might be able to solicit some donations for our scholarship fund. So I shared some of the work we were doing, and I was shocked at the response. Some of my, I shared stories about students and hope and change, and my friends focused on making sure the university wasn't taken advantage of by those people. They were concerned that why would we recruit students in recovery to come to the university? Is that kind of what we wanted to be known as? And so I pointed out, as in a gentle way, that those students are already here. And when we work with students in recovery, we're actually way ahead of the game. And so I think all of us in this field have that same challenge. Okay, Kimberly. Next slide. There we go. So this week I was sent an op-ed by Andrew Sullivan. He wrote, "The opioid epidemic is this generation's AIDS crisis." At first glance, I was skeptical about his comparison. To be honest, I thought it was overstated. But as I read more, it started to make sense. He reported in 2015, 52,000 people died of a drug overdose. And then he compared that to the peak year for deaths with AIDS, and it was 51,000 in 1995. He also mentioned that why in 1995 there was hope that those HIV deaths were decreasing. We don't see any decrease in the near future related to our current opioid and other drug crisis. So we're going to talk about challenges today of implementing prescription drug abuse strategies. So presently, there's less consensus for increasing awareness and knowledge of skills to prevent substance abuse or prescription drug abuse. Information dissemination is challenging. Even though underage drinking is illegal, simple drug possession is often perceived as more illegal. And that was the experience I had with my friends as we all sat around drinking and in front of their children, but all stopped. So it's challenging to develop social marketing campaigns supported by the campus community that do not implicitly or explicitly prohibit drug use. Recently, I searched the web of science for publications on risk and protective factors. I used the keywords alcohol abuse and prescription drug abuse. So I found 167 articles related to alcohol use risk and protective factors, but only 9 related to prescription drug use risk and protective factors. So it's clear we don't have the same type of empirically tested strategies to address illicit drug use as exists for alcohol. I believe the ambivalence to respond to prescription drug use may lead to inaction or delayed response to a critical area that threatens students' academic success and physical health. If, as Sullivan believes, the opioid epidemic is this generation's AIDS crisis, what will we do? What can we contribute as healthcare professionals, wellness directors, and so on? So it's important to acknowledge the specific challenges, and I'm going to do so right now. First, prescription drugs have a therapeutic benefit. We don't want the outcome of our prevention efforts to make students fearful of using drugs prescribed by their physicians. I think that's a really important piece, and how we disseminate information, how we talk about prescription drugs. That's an easy part to get left out in the communication if there is a therapeutic benefit. Next, alcohol and other drug prevention is the most recognized descriptor for substance-related educational programming on college campuses. I'm called the AOD guy all the time. Frankly, it's kind of annoying. However, alcohol has been the focus of most of the work for decades. Until recently, other drug prevention has not been widely discussed, and what I think is that for the first time, we're beginning to see other drugs as the elephant in the classroom. So, one of the difficulties garnering support for action on prescription drugs is their risk relative to alcohol use. A low percentage of students report abusing prescription drugs. However, the pharmaceutical risks associated with overdose death or permanent brain damage are much greater for illicit drugs than for alcohol. And so this is a conversation that we have to have with campus decision makers and policy makers, because unlike the binge drinking narrative, which was Henry Wexler and students are dying to drink, those numbers were big. And we're not going to see the same numbers when it comes to prescription overdose prevention. Similar to early alcohol prevention efforts, professionals who have experienced prescription drug use or addiction come from a background, a treatment background. And the strategies for treatment options and referrals, they tend to get the most attention. And as a result, prevention strategies become a more difficult conversation for student affairs professionals. So how do we move the conversation outside of the medical or psychiatric model and into the prevention and wellness area? So this is exacerbated when there's an expectation followed by an unfunded mandate. I'm sure none of you have ever experienced that. That student affairs will develop effective strategies to reduce the incidence of prescription drug abuse. However, there may be little guidance. So like many strategies developed over the past 20 years to reduce alcohol use, these strategies, when applied to substance use, are counterintuitive. The other piece that I want to mention is, how do we acknowledge the lack of consensus regarding how to prevent prescription drug use? So currently, there's consensus among stakeholders that there's a risk of drug abuse, prescription drug abuse. There's clear evidence we're in the midst of a crisis. However, there's less consensus about what to do. And hopefully today we'll provide some early steps and strategies and how to move forward. As I mentioned before, the 2002 Surgeon General's call to action changed the narrative about alcohol use on college campuses. High-risk traditions and permissive attitudes related to drinking were examined, and for many campuses, a new narrative was created. I know on my own campus, we created a new narrative around tailgating. So harm reduction strategies on college campus related to alcohol use are more typical than they ever were before. Yet harm reduction is not associated with prescription drug prevention for legitimate reasons. There's growing consensus around providing information on prescription drug abuse risk factors, but aside from refusal skills, there's not much consensus for skill building strategies related to mediate the development of a substance use disorder. So on that note, let's start with specific strategies and how we can leverage these strategies to act. First, a review of prevention from a public health perspective. Universal and selected prevention services are targeted for a general population or specific subpopulations. And I think the Institute of Medicine graph is a really nice visual way to discuss the continuum of care. And if you're not familiar with this, I suggest you do so. I've actually got a bumper sticker, and not really. So understanding where we fit on this prevention, treatment, and maintenance continuum is really important. So when we talk about indicated prevention strategies, what we're really looking at is more of an individualized or one-to-one or very small group problem identification and referral service. So the graph outlines our presentation. It's important to keep in mind this is an overview. We're going to cover a lot of ground and hopefully leave you with several questions and even more ideas. First, I want to go over some basic strategies. Information dissemination is intended to increase awareness and knowledge of the risks of a health problem, in this case, substance abuse, prescription drug abuse. Skill building is similar to information dissemination. It really is more of it's a face-to-face and it's interactive. So information dissemination may be poster campaigns. It can be, it's a one-way communication, whereas skill building becomes a two-way communication. Problem identification referral services. So this is an individual strategy, and it's designed to identify students who've abused substances in order to assess if their behavior can be reversed through education. The goal of problem identification is to enhance the protection of the student from identified risks. However, really important to keep in mind, this strategy does not involve treatment. And there's some really good reasons, and I'll talk about those a little later. Lastly, when we look at environmental strategies, so these are intended to change campus policies and laws and regulations. And we're also looking at rules to strengthen campus and community regarding the initiation and support of prevention services. I think about environmental services as really a universal practice because they affect everyone. The other piece to environmental strategies is what we're going to call community-based processes. So the intent of this strategy is to enhance the ability of the campus community to more effectively make available prevention and treatment services. So that's an overview of what we're going to go over. We're going to address briefly each one of these areas. So I want you to think for a moment how we can inform students about risk and protective factors. For example, marketing campaigns designed to teach students who choose to drink use protective strategies. Students are often encouraged to do any or all of the following: count your drinks, set a limit, pace and space your drinking, eat during and after, never drink and drive, avoid hard liquor, avoid drinking games, ask a friend to let you know if you're saying or doing embarrassing things. I'm certain many of you have these memorized, and probably many of your campuses have used similar strategies in marketing campaigns. Let's think if we applied the same reasoning to prescription drug abuse prevention, what this campaign might look like. So I want you to imagine this is a social marketing campaign on your campus. If you choose to use illicit opiates, avoid snorting, smoking, or injecting. If you stop drinking, or if you stop breathing, you must be revived in minutes or irreversible brain damage may happen. So if you're abusing opiates, always make sure a friend has Narcan and knows how to use it. Now, I don't know that this is necessarily bad advice, but I can't imagine that invoice being signed off on. So, so there's a different conversation around these kinds of strategies, the risk and protective strategies, than what we see historically around alcohol and alcohol prevention. So when we talk about information dissemination, we want to make sure that there's not an implicit or tacit approval for prescription drug abuse. We want the community to be clear that we prohibit drug use. And as Mr. Mackey would say, drugs are bad. And so, so I don't see that changing anytime soon. But until it does, I suspect students will need more, not less, information about the risks associated with prescription drug use and abuse. So it's reasonable to create social marketing campaigns to teach students the importance of reading warning labels on prescription drug bottles and the legal consequences of selling or sharing prescription drugs with anyone. Just because you're sharing meds with a friend doesn't give you a free pass. In addition, more than ever, students come to the campus already using prescription drugs for anxiety, depression, ADHD, as well as prescriptions for drugs that are not abused. I'm certain information about prescription drug risks are not new to you, but I work with students who are skeptical about the relative risk of drug interactions or the harm in taking more medication than prescribed. So here's the important piece. We want students to understand that those labels mean something. Just because you can take 2 pills instead of 1, there is depending on the substance, there can be a reaction that folks don't know about, because it doesn't happen that frequently. But it does happen to people who smoke marijuana or other drugs. So marketing campaigns that teach students it's important to be aware of drug interactions and potential side effects, even for prescribed medication, is useful. For example, benzodiazepines, synthetic opioids are highly addictive. Abusing either can lead to physical dependence and withdrawal. And when the medication is discontinued, there may be continued craving and social and psychological problems. It's especially important for students to understand if they abuse benzodiazepines, for example, they need to see a physician before stopping use of the drug. Unlike opioid withdrawal, which is pretty nasty but not life-threatening, benzodiazepine withdrawal has serious health risks. In addition, stimulant abuse can cause heart attacks, seizures, and strokes. So without resorting to heavy-handed scare tactics, we need to try to reach students at the level of the risks associated with mixing prescription drugs with non-prescription drugs and for abusing prescription drugs. For example, a campaign that demonstrates how Xanax and alcohol may be fatal could be helpful. Counterfeit pills and research chemicals or analogs are also very problematic. Counterfeits may be purchased online as well as on the street. These drugs are marketed as prescription drugs and often labeled with brand names. However, a pill labeled Xanax may actually be fentanyl. Because of this risk, I advise students not to use any prescription drugs they have not received from a pharmacy. It's not unlike the message we give students about date rape drugs. Always watch your drink. Teaching students about legal consequences of selling or sharing prescription drugs, as well as signs and symptoms of any drug overdose, including alcohol or withdrawal, may avert lifelong consequences. Lastly, I suggest information dissemination strategies include a clear understanding of state laws and campus policies related to seeking help for students in need of medical intervention. For example, the state of Florida legislature unanimously passed the Good Samaritan 911 Act a few years ago. This law protects students from being charged with simple drug possession if they contact someone or someone contacts medical emergency services on their behalf. I believe this is a step forward in understanding the importance of the drug use problem and how our strategies have to change. So I want to examine skill building strategies because skill building, unlike dissemination, involve a two-way communication that requires interaction between a facilitator and participants. This strategy aims to develop social skills and decision-making skills, as well as refusal and critical thinking. Fortunately, we can use what we know about alcohol prevention skill building to implement prescription drug abuse strategies. So one of the things that I've found useful is curriculum infusion. Over the past year, my department was given the opportunity to present 2 hours of face-to-face instruction about benzodiazepines, opiates, and stimulants to almost 2,000 first-year students. And these were in classrooms no bigger than 30. We hope to expand this program in the near future to include nursing students, psychology, social work, counselor ed, and higher education leadership classes. We've tailored the curriculum for fraternity and sorority risk managers, as well as RAs and GAs in housing and residence life. And we found these strategies to be very helpful, especially around the prescription and illicit drugs. Everybody seems to be okay talking about alcohol, but when we start talking about opiates, especially when we start talking about routes of administration, there seems to be this, there's less concern if somebody's taking a pill than if they're crushing and snorting it. And so having conversations, open and honest conversations, I believe helps the helpers to be aware and to be less judgmental. We're working on small group facilitation because developing a more interactive group session for high-risk students, I think, is really important. Lastly, bystander training is a critical need. There are several bystander programs for suicide prevention, sexual assault, and domestic violence prevention, and even alcohol abuse prevention. However, there's little in the way of bystander training for illicit drugs that include prescription drugs as well as other illegal drugs. And so, again, how difficult is it to have a conversation with someone about their heroin use? Very difficult. I've had those conversations, but it doesn't mean we can't create a dialogue and we can't find out what it is that causes the bystanders to be afraid of intervening with a friend. Okay, so I want to talk about.
Can I just add one piece to that? Is you mentioned, having a conversation about heroin, but I think that actually is probably a little more difficult than having a conversation about, concern over someone's prescription misuse or abuse. And yet also challenging because it's hard for people to identify whether it's misuse or abuse, or again, afraid of putting a judgment on those individuals.
Well, one of the things that a dynamic in Florida, I don't know, some of you may be familiar with the documentary OxyContin Express, but Florida was the hub of prescription drug abuse distribution. In fact, I think 90% of the opioids, prescription opioids, came out of Florida at one time. And when they when they tightened that up and created a drug monitoring system, what I saw, and I certainly saw it with students, is a migration from prescription drugs to heroin because of the cost. We saw that students who was costing $20 to get an oxy off the street could get black tar heroin for $5. And so while I agree with you, depending on where that person is at, that individual student is at, how desperate they are, and what the supply looks like, you may well have the conversation around heroin as well as the prescription opiates. But I agree with you that it's a much more difficult, or it's perceived to be a much more difficult conversation when we're talking illicit drugs versus prescription. Did I cut you off?
Nope, I'm still here.
Okay. Very nice. All right. So when we talk about problem identification referral services, like I said before, we want to make sure this doesn't turn into treatment. It's a small group or an individual strategy that's intended to identify students who've abused substances and assess if their risky behavior can be reversed through education. So the goal of problem identification referral is also to enhance the use of protection strategies and reduce or eliminate identified risks. In the alcohol realm, Basics is a great example of problem identification and referral. Challenges for implementing this strategy include managing the implicit or explicit bias of illicit drug use. I've determined that even though underage drinking is illegal, when we talk about the stigma associated with prescription drug abuse and having those conversations about risk and protective factors, it becomes a daunting task. In addition, the use of harm reduction, and the sanitized version of harm reduction is called risk and protective factors. So harm reduction may not be supported on your campus. I know the times that I've discussed it, I've had to have conversations on my campus that abstinence was on the harm reduction continuum. That was important for some people to hear. You have to be patient. I've learned to be patient with the campus until they catch up. And if they don't, I suggest you find a more rewarding experience either on your campus or elsewhere, because it's really difficult to be that voice in the wilderness, and I don't know that it's sustainable. So another challenge is the implicit bias of staff. I'm talking about staff members who work with students, staff members who are sympathetic. Even those students need to understand their own bias before they put themselves in a position to engage a student in a conversation about their prescription or illicit drug use. If you don't have a team of people you trust and you can be honest with, it's important to find those people, because if you're going to work with this population, again, a highly stigmatized population who this isn't their first rodeo. Often they've experienced trauma, or they've experienced disappointment or abandonment for many years. And when they come to campus, we're seeing a culmination of that and their substance use. So it's important to find some people who you can talk to, and it's a safe place to process your feelings and your thoughts and your attitudes. Because the first contact you have with a student sets the tone for their future participation in helping relationships. If shame and guilt are perceived by the student, future resistance to intervention or treatment is very likely. Lastly, it's important to let students know if your office can guarantee confidentiality. Confidentiality may or may not be guaranteed for students who are seen outside a clinical setting on your campus. This is an important piece to to find out in advance. Being aware of your campus policy and limits of confidentiality are very important, and students owe that. They're owed that. That's almost an informed consent. So for example, if your campus has a zero tolerance for illicit drugs and you're expected to report when a student confides in you, like, what do you do? And that's why letting students know ahead of time what you can and can't protect in terms of information or confidentiality is important. So despite the challenges that I've just described, I truly believe we can make a positive difference in the lives of students. And here's how we can do that. One, I think we can help build surveillance systems to identify students who would benefit from education referral. The DAS-10 is a really nice brief screening tool, similar to the audit in terms of its 10 questions, and it's a scale. So for example, if health center providers were to use the DAS-10 on students that were new patients or once a year, that creates a safety net, and it also creates an opportunity to assess students for prescription and other drug use. In addition, the campus office of student conduct, your local law enforcement or university police, and the court systems can be good partners. I found referrals for mandated assessments to be very helpful. And I'm amazed at how students are willing to share information that I didn't think they'd be willing to share. Lastly, developing relationships with student organizations that give them confidence to ask for help is important. So it's important for you to be known as a resource for those students. So the next section is related to interventions within the campus community. I truly believe student affairs professionals are best positioned to lead the university in organizing, planning, and enhancing student services. So here's what you can do within your campus. You can help manage stigma related to institutional barriers associated with substance use prevention. You can find allies among faculty, administration, community members to help you advocate for additional funding. It's also important for you to advocate for bystander intervention, like existing training for suicide prevention, sexual assault, domestic violence, and so on. And I think it's vital to create an advisory board of director level or higher level administrators so you can institutionalize prescription drug abuse prevention. And if possible, creating an integrated campus system of prevention, treatment, and recovery will increase the profile of your risk and bring in multiple partners as well. Lastly, if you have a community coalition, and most communities do, you want to get involved. So moving on, it's
Tom, can I just mention one piece here too? I think even though you had put actively participating in your local drug-free community coalition, it's I know it wasn't purposely on the bottom of the list, but I was going to say that for some campuses, starting there is helpful. If you can't start on campus, if campus processes or organizational structure is a challenge, and you may not feel like you can do, pull together an advisory board or advocate for additional funding and those types of things, that starting with the local drug-free community coalition can be a great place to start, because it can certainly help elevate the issue and give you a sense, give practitioner or whoever is trying to lead this charge kind of a support network, so to speak, and maybe potential starting points.
Absolutely. So when we talk about environmental management, one of the things that I think is important is that we do needs assessments, and we utilize our community partners to to help with that. So a couple years ago, we did a community needs assessment of substance abuse treatment services and support in our community. We interviewed leaders of 12-step groups in both Orange and Seminole County to create a list of support group meetings that were more versus less student-friendly. We also networked with local community treatment providers to determine if their treatment philosophy was adaptable to harm reduction or moderation management strategies. When we do assessment, one of the things we try to do is match our students with treatment providers that are a good fit. Unfortunately, some of our students found community providers to be not so helpful. Apparently, their favorite paradigm was the addiction hammer and the denial crowbar. And so in some ways, that's why we created treatment opportunities on campus. We have an outpatient treatment clinic that's licensed by the state of Florida right here on campus, so that we can meet the needs of those students who aren't dependent but need more than problem identification and education. We can also work with local law enforcement agencies to make Narcan available to law enforcement officers. Last year, we trained UCF Police Department how to administer Narcan. Soon after, the City of Orlando and the Orange County Sheriff's Department followed suit. In the first 6 months Narcan was available, it was administered almost 50 times by Orlando and Orange County Sheriff's officers. Lastly, we can impact the community. In 2016, the Orange County Mayor and Sheriff appointed a heroin task force. The heroin task force exemplifies the benefits of community partnerships. The task force included 20 community leaders from state and local agencies, secondary education, higher education, law enforcement, the courts, medical community, and treatment providers. And we don't have time to go into that list, but we're talking about judges and directors of emergency medicine. It was a very talented group of individuals who were very engaged and very influential. So the task force proposed 37 recommendations, and then these recommendations were handed down to an implementation committee appointed by the mayor, Teresa Jacobs. I'm certain the committee will meet all recommendations, and they'll meet until they're all met. I know this because I'm the co-chair of the 2008 Underage Drinking Task Force Implementation Committee. We've been meeting quarterly for 9 years. Most of the 50+ recommendations we were tasked with implementing have been accomplished. So, kind of take-home lessons in my experience, implementing environmental strategies is a marathon, not a sprint. Institutional support is vital. 1999, President John Hitt of the University of Central Florida was influential in the creation of the Orange County Drug-Free Coalition. The coalition has done lots of work in the community. We've passed ordinances to reduce the hours that alcohol can be sold in bars that consistently served underage operatives. We've created noise ordinances related to house parties. We've just done a lot. We've taught physicians how to screen for substance abuse, provided free hospitality management training to bars and restaurants. And so none of this would have been possible without the support of Dr. Hitt and the Vice President of Student Affairs, Mary Beth E. Haas. So in the op-ed that I referenced earlier, Sullivan remarks, "This plague many of us who are cocooned in urban, prosperous bubbles can ignore, but if we do, we'd be mimicking the same indifference Americans exhibited in the 1980s and early 1990s related to the HIV crisis." So these environmental strategies can help those cocooned in urban, prosperous bubbles to work together. So I hope the take-home message for all participants is that we can implement at least one strategy discussed today on our campus tomorrow. Some campuses' prevention efforts are further along than UCF. Some are about the same, and others are in early stage of development. What I've learned is it's not important to focus on where your prevention services are, as it is important to think of where they're going. So, as leaders on your campus, as agents of change, I want to ask you a few questions. First, who on your campus is willing to advocate for implementing best practices? Who in your campus is willing to, and who is not? And of those who aren't, are they likely to change their mind? And if they aren't, do you have the time and energy to attempt to persuade the unwilling? For those on the fence, you want to find the time and energy to persuade these stakeholders. And who is willing to lead with you? More importantly, are you willing to share leadership responsibilities? Lastly, and I've learned this because I've stepped into it a lot, but who will step up without stepping into it? I suggest looking for partners who are good at building bridges, not blowing them up. So lastly, as we evolve, I hope all of our prevention efforts move in the direction of student well-being. And in the next slide, these thoughts are really important because if we can move students to well-being, then a lot of these other problems will take care of themselves. And the reason I say well-being instead of wellness is well-being is about hope, and it's about health versus the absence of disease. So thank you. I've talked as fast as I can, and I hope it was fast enough. Kimberly?
Thanks so much, Tom. And we had a few questions come in that I believe, just due to time, we want to be respectful of everyone's time, certainly. So we are going to respond. Tom and I will look through some of those questions. There weren't a high number, just a couple, like I said, and we will respond to individuals if they're more specific to particular campus situations. So I want to just finish up with a couple of announcements. One is I had alluded to earlier, the online course that we are in the process of developing at the end stages of developing. And so that will be available again in our course catalog shortly. You can see here some of the goals and focus of that course. And it really does address a number of the issues that Tom touched on today in this webinar, particularly around information dissemination and skill building, and just making, again, an opportunity for students to interact in a way that they are, can best learn this information and then apply it in their everyday life on campus. The other piece of information is we have just completed a rework of the higher ed, the previous higher ed center's document on complying with the Drug-Free Schools and Campus Regulations, or EDGAR Part 86. And if you are interested in receiving a copy of that, we're happy to send that along. Please, in the questions section, if you could just type EDGAR, and we will get that information to you. And then finally, this June, we are going to be hosting our 8th, I believe, annual research summit. And this will, again, be happening in Boston, June 12th through 13th. And for those who are interested, please write summit in the comments or questions box, rather, to receive additional information. We'll contact you and happy to share further, as I said, further information on how to register and also take advantage of a discount for attending today's webinar. So on that, I'm going to just wrap it up. And Tom, I don't know if there's anything else you want to share. Otherwise, I will turn it over to Michaela. And we thank you very, very much for your time today. Appreciate it, and look forward to following up and also answering touching base with those folks who have provided some questions for us.
Yes, thank you.
Hey, so Michele back here. I would like to join Kimberly in thanking very, very much Dr. Hall for having agreed to present on this topic today with us. And of course, extend the same thanks to Kimberly, who's done a great job of, first of all, inviting Dr. Hall and then worked with him to put this together for our audience today. And I hope, I see there's still, over 260 of you that are still with us. So that tells me that this has been a very engaging presentation. And I think what the audience can benefit from is you both combine expertise in analyzing this topic and unveiling and uncovering the nuances of this aspect of prevention, that it's not necessarily something that many schools are equipped with if they are coming at it from a point of alcohol and other substances prevention. So I'm glad we covered this topic today. I'd like to again extend a thanks to Kimberly, thank Dr. Hall for being with us, and obviously thank all of you who have registered and attended today for being with us. I just want to remind everybody that a copy of the slides and the full recording will be sent in a follow-up email. I'd also like to say, for those of you who are still here who have not had a chance to review the EverFi platform for training in Title IX, campus sexual assault and substance abuse prevention, that we have a comprehensive platform. So if you're curious to see what the training platform looks like, feel free to type in demo in the right-hand side of your screen in the question box where you've putting your questions, and we will make sure that somebody on our training expert team reaches out and shows you around. Lastly, we've said this at the beginning, I'd just like to repeat it. Once you close out this login for the webinar, a survey will automatically launch where we'll ask you to tell us what you thought of the event today. We love to receive your feedback, and we do take it in great consideration for designing future events. So if you could please do that, it takes 2 to 3 minutes, but it's very valuable to us, and we hope to be always providing you with events that you care for, and so that's one of the ways that we can gauge your interests. That being said, thanks everybody. We've come at it's now exactly 12 p.m. Pacific and 3 p.m. on the East Coast. We have reached the end of our webinar. I'd like to thank one more time the presenters and all of the attendees, and I encourage everybody to stay tuned for our next events. Thank you very much for being with EverFi.